Well, welcome everyone. Some of you know me. My name is Jim Rosenberg. I'm the I'm the director for our executive MBA in healthcare leadership, and excited to be here tonight with all of you and with Clarence Williams, who I'll let introduce himself more, but he's joining us from Children's National Hospital up in DC, where he is the director leading involved with many of their telehealth activities with a deep background in telehealth. So really excited to have him here tonight. He's also a healthcare leadership graduate, class of 2019. So always exciting to be able to bring back our experts and our students and engage everyone together. Today's event is part of a series of activities that we've been calling our learning community. We're trying to find more ways to bring experts to create room for conversation so we can continue to support you in your day-to-day work, whether you're involved with us in a program or you're just part of our community, part of the lifelong relationship we have. Quick thing on logistics before I hand the control over to Clarence. We'd love to have this as a conversation, so please feel free to jump in with questions. You can use the chat as well for questions, and I'll be keeping an eye on that. I can raise those to Clarence's attention as he's talking right as they come up, or in some cases we'll queue them for a bit later. Do me a favor, just make sure you've got your chat box open, it's working. If you got it all set, send me just a yes or you're ready to go in chat, or send it to everyone, and then we'll know we got everybody's tech working the way you need it to. Everybody finding their chat okay? Okay. So it'll send to me. It may not send to everyone. It'll send to me privately. That's okay. I'll keep an eye on the chat as we're going. So we got a few answers in there. Everybody else okay? Everybody connected? Cool. We got a few more folks showing up. All right. If anybody's having trouble, you can unmute and just call, hey, I need help, or we'll catch you in the chat too. All right. Well, hey, with that, let me hand things over to Clarence. Clarence, we should have you set up as a co-host and able to take control for slides and conversation, and I'll step back here. Thanks so much.
Thanks, Jim. I appreciate everyone's time this afternoon. As Jim stated, I'm a graduate of last year's IMBA class and really enjoyed the program. It's almost ironic to have gone through some of the supply chain simulations and exercises and then immediately after find ourselves in a bit of a supply chain constraint. So I've worked in telehealth for a number of years now, and frankly, I've kind of gravitated toward this line of work because it was fun. Several years ago, I was an MHA student and did a resident and fellowship, which really allowed me to kind of ricochet around large health systems and enjoyed it so much I kind of found myself in a telehealth type of programmatic leadership role because it gave some of those same experiences. And this is also back during a time when it was a bit more difficult to do this type of work, kind of pre-smartphone era, if you will. So for tonight's discussion, I just organized a few kind of talking points, and after kind of giving a brief overview of what we do here at Children's related to telehealth and virtual care, I'll try to touch on what I think is maybe a perspective that everyone in the audience can relate to wherever you find yourself in the healthcare ecosystem. So hopefully we can have some pretty good discussion there, and feel free to ask any questions or pursue a given topic at any time. So having said that, here at Children's National, we're really a critical care type of hospital for children in the DC area. We have about 320 or 30 operating beds, most of which are critical care, and it's really a tertiary care facility for pediatrics. Generally, the sickest of the sick kids come here. And you can imagine some of the effects of being located in this region, the nation's capital, down the street from roughly 100 or 30 or so embassies and consulates. And so we have an international footprint as well as supporting regional providers and institutions as the only standalone pediatric institution in this immediate region, especially DC proper. The picture you see before you is kind of the bunker style of telehealth. We do a lot of that here at Children's, as so much of our med staff is really focused on critical care and managing kind of the sickest of the sick kids. Even our ambulatory care or primary care practices, who are mostly employed, also focus on managing this complex population post-discharge. So there's a real focus on research collaboration as we're academically affiliated. But these providers are really the type of gravitate toward challenges and are oftentimes looking to manage the most complex and the sickest of sick patients. As a dermatologist told me during my tenure here, he wasn't really interested in quote unquote suburban dermatology. He was really interested in managing kids in critical care environments. So Dr. Lopez is pictured before you in a bunker style. He's a cardiologist who's working in kind of a cardiac critical care command center. So it's a combination of intensivist workflows, specializing in kind of heart failure kids. And the pictures you see below are the robot itself. And this is Dr. Lopez consulting with a care team for a patient who's on the SICU floor. So these photos were kind of snapped pre-COVID, but you can imagine how much more prevalent these activities have become given some of the risk associated with entering patient rooms for COVID positive children. I will note that this is definitely a destination for COVID positive patients, as one of the, if not the leading expert in pediatric infectious disease, is the head of our infectious disease division as well. So going along with the theme of kind of the cardiac critical care, this is just, I think, one of the more interesting use cases that we have here at Children's National. If you kind of read up from step one of what Dr. Lopez and his team would be doing in the command center, they're using a type of analytics platform that enables or has machine learning and AI in it that really enables prediction of cardiac events, specifically heart failure type of events. And so it's kind of a brief storyboard here is that there was passive surveillance, Dr. Lopez and team in the command center. And then there was the virtual rounding with the telehealth robot. And if you're unfamiliar with cardiac critical care in peds, the units are typically shaped in kind of a semicircle because the care teams literally are sprinting to the rooms if there's a cardiac event. So you might see 3 to 8 different clinicians in the room for a patient who's having a cardiac event. So the rounding can be done in a way with a robot that prevents you from really having to give the role of a cameraman to anyone on the clinical staff. And that's kind of a satisfier for the clinical teams who don't have the burden of kind of pushing around a nursing cart with video conferencing stuff on it. And so upon kind of rounding with the patients, Dr. Lopez sees that there's a pending type of cardiac event. So if you kind of look at the trending of the patient here, this is the point where step 2, where Dr. Lopez says, hey, there's a patient having an event, maybe we should look into it. And so at step 3, this is when basically a button is kind of hit, for lack of better words, in the command center, which alerts the bedside team who are in the same facility, but they're several hundred paces away from the command center. And so upon receiving that alert, the care team responded and the baby was assisted and avoided a cardiac arrest. And so that's the type of surveillance and patient safety that's really enabled through some of our workflows. And I just use this example as it's a more interesting type of workflow that's, I think, less prevalent in most communities, as there are just so few cardiac critical care intensivists in the pediatric world. Here's just another photo of Dr. Lopez kind of rounding with parents for a patient who looks fairly stable at the moment and will soon be admitted to a kind of mid-surge or just an acute care floor after being discharged from the SICU. So just to key in on a few of the attributes of telehealth program here, I've kind of aligned some of this into what I would consider to be pretty significant domains. And let's kind of start with the strategic oversight and value. So on the provider side of the telehealth world, the question is, although we can do a lot of cool things with the tech, does it create value for us? Are we spending money on fun stuff, or is there an actual tangible return on investment? And so those of you who have kind of had some, I guess, exposure to telehealth more recently, there's always the big resource allocation question when resources are constrained, like they are in this kind of COVID environment. And so ensuring that there's not only alignment with kind of a strategic oversight group, whether it be senior executive group who has operational oversight, or if there's maybe a strategy office within the health system or the entity, ensuring that there's alignment between the programs and the activities and the roadmap for the organization, I think, is key. And a few of those key components of that alignment, I think, have to do with physicians and how they're aligned. Here at Children's, our providers are almost exclusively employed, which makes the alignment issue so much easier, right? But at my previous employer, which was a very large health system in the Midwest, it was very difficult to really ensure that there was value, at least net neutral value, to the consulting specialists, because you might have 5 or 6 different physician groups on a critical care floor, for example, all of whom are interested in some level of teleconsulting or helping to augment their services with specialists who might not be in the local market, but could be somehow aligned in another part of the health system. And so ensuring that the physician alignment really kind of speaks to the expected outcomes of kind of virtual health strategy, I think, is a critical starting point of these virtual workflows. Oftentimes, I think it's the resource allocation and the physician engagement that determine the success of these programs. Like I said, I've spent a lot of time in different med staff meetings, both rural and urban and kind of suburban. And I think the critical conversations from the med staff at the beginning of these types of activities is, does this make sense? And is this the type of service that you would use? If so, then what's the value attribution of that? And if not, then perhaps that allows us to move on to other activities without spinning our wheels with med staff and kind of organizational alignment types of issues. On the more exciting end of things, I've had a couple of experiences where there was some pretty excitable activity between med staffs and kind of the board of the hospital, or even the operating authorities of the hospital, knowing that oftentimes these workflows kind of change referral patterns or even patient loyalty, and potentially take market share or result in loss of market share. So I think physician alignment is one of the more critical components of kind of a structured program, whether in the health system or small organization. And then, of course, if you're on the payer side or even tech company side, understanding that ecosystem and alignment constraints and challenges of these workflows in complex environments, I think, is equally important. As I often kind of interact with vendors at tech companies, who, in my opinion, don't seem to have a lot of insight into the true nature of how some of these shared decisions are really structured and executed whenever there's an alignment issue. I think another key component on the slide, which is on here twice, is payer strategy, which is both in value attribution and strategic oversight. Pre-COVID, I was really like threading a needle for sustainable telehealth reimbursement, depending on where you are in the country. For example, here in the DMV or DC, Maryland, Virginia metro area, you have the burden of navigating multiple jurisdictions, all of whom have different rules. So the payers in, let's say, Virginia might have different rules than those in DC, and likewise for Maryland. Same thing with Medicaid, and if you're in the adult world, Medicare populations. And so understanding the payer strategy and how you as an organization or you as a kind of third-party vendor to an organization who has the burden of navigating and negotiating with payers is also, I think, a critical alignment factor. And of course, builds upon the concept of physician alignment. I think integrated operations are being realized by many organizations in this environment as telehealth is kind of becoming mainstream. And so people like me who've spent kind of time in this sector of healthcare have always thought, hey, at some point, telehealth becomes mainstream in care delivery. Most of us didn't expect it to be catalyzed by an epidemic, but I think in this environment, we're seeing how, those systems really react to a mainstream approach to virtual care. Not to belabor this slide, but I think one of the other most critical components is stakeholder engagement, ensuring that the end users are driving the requirements for what is ultimately implemented and sanctioned as a path forward on some type of capability roadmap, and ensuring that there are ways of gaining feedback. So we have existing pathways in healthcare, like a patient satisfaction survey, but there are also, I think, ways to engage not only med staff and clinical teams, but patients. And we're seeing really an increased intersection of patient-facing types of technologies that have consumer engagement capabilities, as well as care delivery and coordination. So we kind of see that meshing of wearable devices and telehealth, urgent care products that are made available through health plans, as well as direct-to-patient follow-up visits with your established provider, and then everything in between that's maybe a little flashier but a smaller in scope, such as remote monitoring in kind of home settings. Part of our experience in the COVID environment has been one that I think is prototypical of health systems, in that the crisis emerged. How fast can you rapidly pivot and maintain not only some bearing on your long-term strategy, but also make the adjustment in an environment where most organizations are having to telecommute, and then with healthcare, of course, that further complicates operating with many kind of teams who are used to being in close proximity. So taking that, the benefit of that face-to-face interaction, that kind of hallway engagement, if you will, putting it in a virtual environment, while also trying to rapidly pivot care delivery systems has been quite challenging. I would say that I was kind of fortunate enough to have been somewhat familiar with the process, as my catalyst in the telehealth years ago during a residency and fellowship was really a rapid deployment of telehealth capabilities type of project. Obviously, it wasn't in a pandemic crisis, but that at least I think gave me as one of the lucky few to have some type of bearing on these rapid implementation aspects. And so within about 2 weeks, we had 1,200 or so clinicians, including just about all of our med staff who were onboarded for telehealth. And so we had multiple systems that we were using, and it's funny because we had to deploy our backup solution as we were in the middle of a vendor switch for synchronous and video-enabled telehealth visits. But surprisingly, it went better than expected, to the extent that many of us were shocked at how well it went. And I think part of the takeaway there was really leveraging the existing channels and capabilities of the organization, knowing that we had 100% leadership support from both operating authorities and governing on the board. And so that fast pivot to a virtual environment allowed us to peak out at about 85% of our ambulatory visits were completed via telehealth. We also deployed many endpoints to the inpatient environment. Again, as we're really a critical care institution, it helped us enable our care teams with respiratory therapists and nurses and pharmacists to participate in some of the rounding and consult on patients who may or may not have been COVID positive. And many of these providers were, by regulation in DC, kind of mandated to work from home or work remotely. So a very rapid pivot, but it's been a positive experience. Kind of touching on the uniqueness of this organization. This is a workforce excerpt from American Board of Pediatrics a couple of years ago, 2016. And this is really a crosswalk between some of the most common specialties in pediatrics with the other subspecialties. So just to key in on a couple. As of 2017, there were only 115 practicing providers who were triple boarded with both critical care, pediatrics, and pediatric cardiology. So that's kind of like Dr. Lopez's team in cardiac critical care. Even scarier in these days, there are 8 infectious disease providers who are boarded in both critical care and infectious disease. Likewise for neonatology, if some of you might be familiar with NICUs in the country, and Children's has been ranked top NICU for several years in a row by U.S. News and World Report. And so many of our neonatologists, I think, are probably in this cohort. And I actually found this one a bit eye-opening when I first joined the organization a couple of years ago, that you'd think there'd probably be many pulmonologists who were triple boarded with both critical care and pulmonology, but actually not a lot. And so I think part of the value that organizations like Children's, are probably a dozen or so in the country who are freestanding pediatric critical care institutions, is we're really kind of a supplier of subject matter expertise that doesn't really exist outside of large critical care units. For example, if you're an infectious disease provider here, it's pretty common for you to round with care teams for kids who are in cardiac critical care or in the NICU. For many of the kind of smaller scoped ICUs that are maybe embedded within an adult hospital or health system, you don't really see that depth of subspecialties there, nor do you see that level of expertise typically with the allied professional care team who help support those specialty providers. And so in this environment, we've really kind of found an opportunity to provide value to international and domestic institutions by using telehealth to deliver some of that subject matter expertise to other organizations who are also likewise managing critical care kids in this kind of pandemic. A quick slide on kind of basic portfolio structure. So generally there's ambulatory inpatient, and here are a few, not all, but just a few use cases. So we'd have the ICU that would have like NICU, the PICU, the cardiac critical care unit. And within that, we have different types of workflows. Many of those workflows are supported by a combination of technologies, as we've seen a lot of EMR capabilities expand to include telehealth. Likewise for other types of traditional sort of digital health solutions that now have adopted or seen value in adopting the patient-facing component to help integrate some of the ecosystem. So it's really been interesting to kind of see a stampede from the vendors and biomedical manufacturers to all of a sudden try to leverage or tap into some of the telehealth workflows and those supplement capabilities. So in general, the way that telehealth programs kind of mature for those who maybe don't live in the space on a daily basis is taking from Van Dyke and Schutz's model, kind of see this prototypical maturity going from handful of projects going to a well-optimized enterprise. And so the reimbursement historically has been what really prevented or kind of stifled the growth and expansion of many telehealth programs around the country, where you're kind of chasing reimbursement or some type of financial feasibility and sustainment that's been limited by payer constraints. And so in this environment where many of those rules have been lifted, you see organizations kind of similar to our experience, you make a pretty big leap from somewhere around ad hoc and managed programs to all of a sudden having the ability to kind of optimize something across a large health system or a large network or entity. And again, this is just some focus on stakeholder input to ensure that we really drive value. I think that's one of the key roles that telehealth plays. So kind of shifting the conversation to the marketplace and what we're seeing with organizations and companies who are increasing their interest in their footprint in the healthcare space. Traditionally, there's kind of been a chasm, if you will, where kind of Silicon Valley didn't really understand healthcare. Healthcare didn't really understand Silicon Valley. And we're seeing that gap really be reconciled by a number of collaborative types of projects that are focused on the consumer needs or some form of really cash-based transactions in healthcare. And so here's a good example from Becker's where Best Buy Health and Amazon are actually leveraging AI types of capabilities and machine learning to manufacture flip phones to better help seniors, or they're going after kind of Medicare population, Medicare supplement plan. And so there are a number of different activities like this that are being partially supplemented and invested by health systems. We're collaborating with these huge organizations who have quite robust distribution capabilities that they're bringing to the healthcare space. Likewise, here's an article that posted within the last week for those of you who are kind of Becker's junkies, if you will. Aetna is coming up with cost share waivers that kind of blend commercial telehealth, behavioral health for Medicare services. And those waivers are set to expire at the end of this calendar year. Of course, there are a number of things that are, I think, to be determined related to emergency declarations that support stimulus in healthcare and kind of supplementing some of the healthcare spend by provider organizations. But I think that this is one of the interesting solutions from the payer side where we're looking at high risk, kind of perhaps dual diagnosis Medicare population with behavioral health supplement plans to kind of increase access, but also reduce the cost. For example, Jerry Psych is often unavailable in rural communities, and I can tell you firsthand, there are places in the country where this population might spend a couple of weeks in the emergency department in observation, waiting on a court-ordered psych eval or just access to a psychiatrist. And so you see these types of solutions coming from the payers. Likewise, you see these kind of soft benefit, consumer benefits, whether it's Costco or whether it's CVS Health, you see them kind of leveraging their patient loyalty programs with some type of low acuity footprint in healthcare, thinking that there's an opportunity to reduce the spend or create some form of cost saving or value stream, not only for the insurance companies, but for the tech providers or the solution providers themselves. And so I really expect to see an increase in this level of activity where these large sort of distribution experts will continue to dabble into the space of digital health and increasingly sort of cannibalize some low acuity opportunities in the healthcare space that were traditionally, I think, owned by provider organizations and private practices. Likewise, I thought the Heal and Humana partnership was an interesting headline that emerged, last couple of months. And so here you have Heal, which is a company that really has a model that kind of phased out, but was very prevalent decades ago, where you have the provider who does a home visit to the patient. And these are primary care. These aren't kind of home health visits. This is literally kind of the model where the doctor takes his briefcase to the patient's home and is doing the exam. But they're supplementing that with a digital footprint. So if you think about, a decently populated area, let's say Washington, D.C., for example, or Chicago, where you might have many members in a health plan within a fairly dense area, especially if there's a lot of vertical residents, like downtown Chicago. One provider can go and kind of work that area and have multiple face-to-face visits, supplement those with some form of a digital health workflow, and that can help reduce some of the spend for high-cost patients or chronic care. For example, if you think about diabetic patients, that's an ideal population to really take advantage of a home primary care workflow that's kind of supplemented with the telehealth footprint. Likewise, if you kind of think about some of the home preventive care screening kits, there are a number of organizations now who are finding ways to distribute home health types of products or equipment or DME to help supplement some of their at-home populations, be it some form of a home health program or just a carve-out for a population health initiative where we're trying to manage a cohort of patients. Seeing more and more interest in health systems partnering with distributors to give that at-home point of care for testing as well as diagnostic activities, be it some form of a kind of sleep study, or if it's literally distributing technology to enable a monitoring relationship between primary care medical home and a complex group of patients. Likewise, we really see an increase in institutional investment in virtual care. And one of the reasons this article kind of caught my eye is you have a large payer, managed care organization, who has an accelerator that's really investing in startups kind of solving these care delivery challenges and these, let's kind of bend the cost curve challenges. And so if you think about these 10 or so companies that are listed just in this article alone, knowing that one of the major institutional investors is a very large insurer, we can kind of expect to see consolidation in this space as we have in, I think, past few years. So on one hand, there's almost like this kind of growth spurt of startups in the digital health space. And in many cases, these organizations or these startups are being acquired well beyond their multiple with a traditional valuation with the intention of leveraging their network. So even if a company, let's say, has yet to make a profit, but they have a footprint with a very large cross-section of the American public that might align well with another vertical or horizontal intentions of a large organization, those are really attractive from an acquisition standpoint. And so kind of see this rapid cadence of mergers and acquisitions in the digital health space as the capital is being infused by these large enterprises who also realize the value of kind of streamlining some of these workflows on the back end to help reduce some of the lives that are covered or at risk in their agreements. Kind of shifting topics. Here's an excerpt from the Federation of State Medical Boards, where many state jurisdictions are have been kind of easing the restrictions to allow for the rapid adoption of telehealth. And so here's just, a sample. I took Tennessee just because we're University of Tennessee. And there are multiple types of executive orders that kind of suspend the rules that have for so long prevented the rapid adoption of telehealth. One of which is out-of-state healthcare professionals being allowed to temporarily practice in Tennessee. If you think about the slide I shared earlier, where in many specialties, there's an absolute barrier to access just out of sheer workforce numbers alone. Easing those restraints allow providers to kind of give their expertise and care for patients across multiple jurisdictions in a way that really helps address some of the healthcare shortage and access issues that are kind of aggravated in this pandemic environment. Likewise, another good, I think, example is where we have insurers who have kind of seen, let's say, a spike in COVID types of claims are now able to make some changes to their in-network requirements. And so you see that in the second to last bullet. But every state has a number of kind of actions that is taken to kind of rapidly enable the healthcare ecosystem to react to these challenges of telecommuting as well as managing complex patients. Here's an example of legislative activity that, being in the DC area, has been on my radar related to some of our footprint in Virginia. So if you think about the earlier slide that talked about the collaboration between tech companies and health plans, there are kind of narrow networks that have been formed. And so this bill seeks to address those narrow networks in that it provides an out and prevents providers from being required to go with a specific technology partner who might have had some contractual agreement with a major insurance company. And so we would expect this to kind of open up the marketplace in Virginia to allow providers and institutions such as ours to get reimbursed for encounters that are delivered to patients at home in Virginia who have in the past been restricted from our services because of this reimbursement narrow network type of clause that's in place between many tech companies and insurers. And so there are many kind of state level legislative activities very similar to this around the country that all are kind of intended to expand the opportunity for patients to access medical services as well as enhance reimbursement opportunities for the providers.
Clarence? Can I just jump in with a question that popped up in chat? I'm sorry if there was a little bit of delay on our side, on the chat side, but thinking about these different places where telehealth is playing, the question was, where do you see the growth of independent, unbiased telehealth services like second opinions on oncology? The feeling that currently the biggest market share being hospital-based, which has a sort of built-in bias. Do you see anything happening around that sort of second opinion market?
Absolutely. I would say that at this point, everyone is in everyone's backyard. And it's oftentimes hard to discern what a given specialist's footprint is because they're leveraging multiple types of narrow network channels. One example is if you're in, let's say, a direct-to-consumer type of product that's traditionally been an urgent care type of solution, but you're a specialist, you could not only see that lower acuity option, but you could also see maybe some form of a primary specialty gatekeeping opportunity there. And so I think about my past experience being in a large network in the Midwest where we had several specialists. We had a part-time specialty practice, but were otherwise either hospitalists or PCPs just because of the prevalence and kind of the demand for their services in that rural community. So in this environment, many of those kind of semi-rural specialists are able to kind of shift from being more primary care to more specialty based since there are so many more distribution opportunities now. And likewise, there are, I think, a number of health systems and startup companies who have realized the opportunities there are in kind of second opinion services where the providers are typically reimbursed on a cash basis or through some form of a negotiated agreement with a health plan or an entity that has risk in insuring lives.
I was going to throw out one more question for you, which I think builds on that with the different risks that are carried here. The question was, is there what kind of objective research projects have compared outcomes, clinical outcomes, resource stewardship, patient experience of this kind of virtual telehealth care to traditional face-to-face care delivery?
Yeah, so I can say over the past several years, there have been several of us who've kind of tried to push the research initiative from a policy standpoint. And historically, the barrier has been getting clean data where everyone's kind of matching apples to apples. I think more recently, we have an opportunity through this data dictionary initiative that is really being led in a collaboration with CTEL, which is the Center for Telehealth and eHealth Law. It's kind of a nonpartisan digital health think tank that provides subject matter expertise to Congress as well as nonprofit organizations in combination with Rutgers University, who helped a lot of that legacy work. And so now we're at the point of finally collecting huge data sets that can really tell the story of how telehealth has been used across the country. And there are several very large healthcare organizations that have opted to participate and submit kind of blind data that is structured in a way that I think is congruent to those data definitions that will allow exactly that type of outcomes-based research. In the past, many of those activities were very programmatic or very specific to a jurisdiction, population, or payer group. Most often we were looking at Medicaid and Medicare claims, just given the availability of data. But the kind of COVID world has really catalyzed the shift toward having in kind of a data study that's published and is kind of standard practice as a benchmark across organizations. So that that body of work is underway. And if any of you are interested in kind of seeing that result, or even participating or having your organization submit information, please let me know, and I can connect you with the leaders of that initiative.
Thanks, Clarence. I won't interrupt.
I think there was a hand raised as well.
If you did have your hand raised and you'd like to ask a question, you want to just unmute yourself and go ahead and ask?
Yeah, I had a question though. And on the recent telehealth Zoom call we had with Haslam, in terms of like licensing agreements, if I'm sitting in New Jersey right now and I'm running my own telehealth company or working for a hospital and I want to render like a second opinion for a patient who's sitting in Arizona, for example, right now I have two options. I have to be licensed in Arizona where the patient lives in order to avoid malpractice, or I have to engage the patient into a contractual agreement that he or she waives all adverse outcomes. Do you think in the near future, especially with this pandemic going on and telehealth being a big push, that this overall like licensing requirement is going to be waived? Because it's kind of counterintuitive in many aspects. If you want to render telehealth, why do I have to be licensed in 50 states where I want to render second opinions? I have to be licensed in my state and protect myself, but I don't have to be licensed in the state where the patient lives.
Yeah, great question. Over the past several years, there's been an increased adoption of the compact, which physician licensure compact. And on that Federation of State Medical Boards website, you would kind of find the states who have opted in. The practice of medicine from a regulatory standpoint most often falls to like a Department of Health at each state, who generally has the rulemaking authority to enforce how providers are licensed in that area. So I think there are a few compacts that can really help support that. A, there's a physician licensure compact. B, there is the nursing compact, which most places, most states are kind of following suit behind the physician or boards of medicine, if you will. And then there are kind of similar compact activities for allied professional or other professional types that might be inherited under the Board of Medicine or some other oversight body. Depending on the state, those requirements could vary, some states would require a type of special access provision specifically related to telehealth. Others might opt for more of a full credentialing requirement. And then I think there's opportunity to look at the rules that are kind of sensitive to the types of services being provided in a second opinion. For example, radiology, I think historically has kind of found a way to operate across multiple state lines, when oftentimes that interpretation is a type of second opinion, but it's not a synchronous telehealth visit, which kind of triggers a different set of rules than asynchronous activities. And so I think as each state kind of wrestles with how best to represent their constituents in terms of enabling outside providers to enter their states and market, we'll see maybe more synergy. But apart from, I think, the pathway that VA opted for, which is national credentialing, I think the states will continue to kind of use those licensure requirements to throttle market competition, to be very candid. If you think about, some of the challenges of being a private practice provider in, let's say, a fairly small community, and all of a sudden, providers from a different coast are entering your market and absorbing and cannibalizing some of your workflow, you as a provider in that local area might feel inspired to reach out to your legislators and have your interests represented, at the state level. And so, I've personally kind of participated in some of that back and forth between, the local providers who are trying to protect some market turf against external entrants. And so we see that kind of back and forth, or that kind of wrestling with territory, not only market share, but kind of the scope of practice, especially related to nurse practitioners and CRNAs.
Yeah, in my opinion, that's completely counterintuitive to the concept of telehealth, which should be medicine in cyberspace. It still respects state boundaries, and hopefully that's going to change in the near future.
Yeah, there's certainly many of us who are actively, trying to advocate for that expansion and spend time on the Hill and various opportunities to give testimony. But I think it's next to reimbursement, it's probably the next greatest constraint for telehealth expansion.
Okay, thank you, Clarence.
So it's kind of a couple of final thoughts, and I've oversimplified the perspectives of the various stakeholders in the healthcare ecosystem, but kind of start from the bottom up related to that discussion is, if you're med staff or you're in private practice, kind of wonder who entered our market because of telehealth, and where are my patients going now? Who's managing my patients? If I'm an oncologist and a couple of my patients are going to a direct-to-consumer solution when they feel sick and in need of urgent care, is that something that I'm agreeable to as an oncologist, or do I expect to have the opportunity to kind of provide those urgent care visits for patients under my care. Likewise, insurers, we kind of saw a sudden dip in spending, related to telehealth and people being constrained, not able to really go and see the doctor. And so the insurance companies began doing things like paying for copays or waiving copay costs, and they'll just absorb the copay costs for telehealth visits and other ways of ensuring that they spend about 85% of their revenues on paying claims. What types of value-based benefits are really derived from, supporting accountable care organizations and those kind of risk-sharing workflows. And then, of course, in PEDS, I find it very interesting to kind of interface with patient families where the parents are typically at, the age where not only are they trying to care for their parents or loved ones, in addition to their selves and their children. And so part of, I think, the value proposition is, why should I enroll myself in this patient portal if I just want to see my doctor? I have to manage mom or dad's care as well as my children. So where's all this information kind of sitting? And I just want to see my doctor, but there are other viable substitutes. So how do I shop for whatever is available, and will my insurance cover the cost? And then, of course, I think health systems are wrestling with all of this, but specifically, how do we stay afloat? Given kind of the market shift in America toward value-based care systems, it seems that COVID not only accelerated or catalyzed the shift toward value-based initiative, but it also allowed organizations to very rapidly perceive the gaps they have in operating capabilities related to meeting value-based types of initiatives and kind of milestones. And so kind of just a summary of different perspectives that people are kind of represented whenever people either reach out or are interested in establishing some form of a virtual workflow footprint. And so that brings us to really the end of kind of the structured discussion that I kind of prepared. It looks like we have about 5 or so minutes left. And so, Jim, I'll turn it back over to you to see if there are any final questions or comments related to the discussion tonight.
Thanks, Clarence. So again, you can pop up a question in chat. Be happy to handle it that way. Or if you've got a last question and you want to just turn off your mic and hop in, we are happy to do that. We've got a small enough group, we can do that pretty readily. Anyone have a question there? If not, I've got a couple that I've heard at different times that I can throw in. Maybe I'll throw one in while we wait if this triggers something. I'm just curious, Clarence, if you have seen, when an individual has an idea for how telehealth could be used, how it can make a difference in a service, but we're inside these large health systems where it's hard to make change. It's hard to work through the system barriers. Have you seen things that work well, like how an individual can bring that idea forward that works better than other ways when you're talking about telehealth change?
Certainly. One of the more effective kind of tools I've implemented in the past was physician championship. So if there are, let's say, very political, capital-rich physician leaders in the organization who are kind of early adopters, they oftentimes can get these types of projects up and off the ground from a buy-in standpoint, especially chiefs of surgeries or any service line that is really a revenue leader in the organization. Oftentimes, I think the value statement can inspire investment or interest in some of these opportunities. I've just personally kind of seen and experienced when dealing with a number of financial executives, for example, in a previous role in a large health system, it was almost like a regular Shark Tank. So, how do I make this value statement to a group of 45 or so CFOs and or controllers? in addition to the physician practices, who would be participating with workflows. And so I think that value statement in combination with clinical championship or physician leadership oftentimes is the right recipe for inspiring investment in some of these kind of structured risk activities related to telehealth or virtual care.
Thanks, Clarence. And we're winding down on time, and I want to respect everybody's schedules. And that might be a nice place to finish, is thinking about how we each as individuals can push forward the ideas that we generate. Clarence, thank you so much for sharing your expertise and your experience with us. Again, thank you everyone for making time tonight. I'd like to just remind you that we at the team here at Haslam are always available as a resource for you, whether that's taking part in our formal degree programs, whether we're helping with an online or an in-person custom program, helping you sponsor others to join in degree programs, or you just have a question that you want to ask, and maybe we can point you to a resource or point you to an expert like Clarence who may be able to help you out. This is definitely recruiting season. I'll remind you that if you know somebody who would love to be part of one of our executive MBA programs, either the physician side or healthcare leadership, please let us know. You can reach out to me, or many of you know Kitty. You can reach directly to Kitty. We'll be happy to chat. And thank you everyone for your time. I hope you all have a great evening.
Jim, I have one last question to Clarence.
Yes, please.
Clarence, with your expertise, which is phenomenal, where do you see the barriers for a second opinion company entering the market, knowing that the hospital-based second opinions are the front leaders right now? Second opinion independent companies are second. What do you think how we could separate ourselves and enter the market successfully? Because I think if you render second opinions, especially in the oncology space, which is our expertise, in an unbiased fashion, but working with an accomplished leaderboard, will reduce costs for insurance companies and large employers, which usually are self-funded, and reduce medical errors. Where do you see the barriers, and what would be your advice?
Yeah, I think one of the biggest barriers is related to an increasing attention to cybersecurity, privacy, risk-related requirements of second opinions that span multiple jurisdictions and even international jurisdictions. I think that's one of the big constraints. The other, I think, is sort of plugging into distribution channels. If you think about the companies that have the greatest distribution capabilities, they're rapidly partnering with similar types of organizations to help manage that risk. I think another way that perhaps a second opinion company can provide some level of advantage is caring for multiple types of populations well beyond the American health system. Kind of back to that specialty slide that I showed earlier, if that's the kind of prevalence of specialists in America, the rest of the world has very few specialties, or that depth of specialty. I can say that having worked with a number of other countries or organizations in different countries, related to just getting some type of specialty consultation there in theater. I think another one is the pricing conversation. So as we kind of see this increase in shift toward the willingness and transparency related to pricing in the American market, I think other places in the world appreciate the price transparency, knowing currency fluctuations and some of those access barriers just related to affordability of these types of services. And I would say finally, the other kind of piece of advice I would kind of think about is where is the physician pool for the second opinion platform? In many states, there's this kind of corporate practice of medicine constraint, if you will, where you have to have the right type of architecture to separate the clinical services from the technology provision. And so in navigating those jurisdictions and those kind of challenges, what are the likely benefactors of a second opinion for those who are trying to ensure that their patients or their covered lives have access to the right type of specialty opinion, and who are also looking to maybe reduce the cost associated with building out their health plan benefits. So I think that's the other space where second opinions really has big opportunity, is understanding, the decreased expense appetite for the private marketplace related to ensuring their covered lives of the beneficiaries have access to services that traditionally have been high in cost.
Good. Thank you so much.
No. If folks would like to stay and chat a little bit longer, if there are additional questions, and Clarence, if that's okay with you, we can take a few more minutes. Again, always want to respect everyone's time. Any other questions out there before we head off?
I have a question, and it's more of a philosophical one. This is Kitty. I don't know how many of the physicians, or anybody in this space, has watched Abraham Burgess' TED Talk on A Doctor's Touch, and he really advocates for that hands-on experience where you engage all of your senses with your patient. And I think I'm interested to hear what everybody's take is on that, and if they think it's an issue.
May I chime in?
Please do.
Yes.
So, Kitty, if I understand your question correctly, you think the detachment from a personal encounter with your physician deprives the patient from an emotional experience. Is that correct?
No, not exactly. He advocates, and you may not be familiar with him. He's done a lot of fiction and nonfiction writing, but he's a physician, and he really advocates for that hands-on experience, and he advocates it from a physician's point of view. When you don't sit down and take the time to physically lay your hands on your patient and look into their eyes and hear what they're saying to you. And so the thing about telemedicine that I think I wonder how much of that is lost, I guess, is my question, or maybe just a observance, I guess, an observation.
My personal opinion on that is telemedicine, telehealth is here to stay. It's actually going to grow. It's going to be like a mainstay of rendering physicians' opinions in the future. I think as long as you have some sort of like personal connection with your patient, I don't think an initial visit on telemedicine going to be very beneficial. But if a follow-up visit on any established patient care, you saw the patient first in the office and then follow up later on over the next couple of years, I think telemedicine is going to be just as good with new technology as it is in a personal visit.
I think that's a great point in acknowledging that telehealth is merely just a tool in the tool bag. But to your point, the organization that really kind of stands out to me, who I think is getting this right, and I say this not being a provider, would be Hill, in that they're supplementing that face-to-face touch where they're actually traveling and meeting with, patients in their backyard during COVID or wherever they can, respect the social distancing types of requirements. So they not only have that face-to-face interaction, but part of that care management happens with virtual tools. And to me, they really stand out in acknowledging that exact point of ensuring that touch is not lost in the care and healing process.
Agreed.
Yeah, I like that answer. I think that's important, because particularly as we move hopefully toward more preventative care than after the fact of, something catastrophic happening to someone.
I mean, what we can negate is as well like the convenience factor, what Clarence just said, like in the COVID and the pandemic, you do not necessarily want to go to a hospital or to a physician practice and expose yourself to potential getting infected with COVID-19, or just like your anxiety or fear that this is going to happen. I think the convenience factor, establishing a connection with your physician over telehealth, like Zoom, Blue Jeans, whatever modality you want to use, I think 24/7 having access to that, I think that's going to be huge in the future.
Wonderful. Well, again, I want to thank everyone for their time. And Clarence, thank you again very much for joining us and sharing your expertise tonight. We look forward to talking to you all more in future sessions or directly on calls and email. Good night, everyone. Thank you.
Thanks, Clarence. Thanks, everybody.
Thanks, Kate.
Thanks a lot. Great talk. Thanks, Clarence.